Here you go. So the Smartee treatment, for all cases and patient profiles, we do have diverse product options. We have 5 product options to choose from, 3 product options for adults. We have the Smartee GE and the Smartee GS, as well as the Smartee Alpha. But for this evening, we will be talking about the Smartee products for growing patients. That is the Smartee Kinder for ages 3 to 10 years old and Smartee Teen for ages 3 up to 16. The Smartee solution for early orthodontic treatment. Smartee Kinder is 2 years management for children aged 3 to 10, and these are the primary dentition, early mixed dentition, and the middle mixed dentition. So here are the common dental problems in occlusal development for kids, ages 3 to 10. We have the anterior crossbite. We see in them posterior individual tooth scissors bite, upper anterior teeth protrusion or anterior deep overjet, space loss for primary teeth loss, posterior crossbite, severe anterior deep overbite, narrow dental arches or dental crowding, and individual tooth ectopia. So according to Dr. Profit, malocclusion is not a disease but defined as a developmental variation of the normal occlusion. And these are the interferences that we see during their early tooth development, such as, of course, we have the genetic factors, racial evolution. We do have environmental factors too. And one of them are the functional factors that we need to consider in teeth alignment, such as breathing, incorrect breathing, sucking, swallowing, pronunciation. That's why these early interferences in their tooth development are the things that we need to address. Number 1 is the occlusal interference. So we do have teeth alignment that we need to address. We have the myofunctional interference, the action of the tongue that plays a big role in their teeth development, and the poor habits that they have. That's why our treatment strategy for Smartee Kinder is prevention and interception of these interferences. We do have different treatment strategies for primary dentition, ages 3 to 6 years old. We have the treatment strategy for early mixed dentition, 6 to 8 years old, and middle mixed dentition, 8 to 10 years old. So what are our Smartee Kinder solution? Apart from having a clear aligner, we do have myofunctional trainers too, and we have a specialized attachments that are smaller by 40%. So our clear aligner provides orthodontic force for tooth movement, and the aligner extends to gum and palatal mucous membrane to enhance the retention. So we do also have the myofunctional trainers that are silicone products to address the malocclusions caused by myofunctional disorders and to improve the strength of orofacial muscles. And the features, the unique features of our clear aligner is having this tongue protrusion. That is the solution K3 or Smartee solution K3 for kids. We do have the tongue crib K3 as well. So the tongue protrusion helps to train the tongue muscle to sit on top of the palate. We know that we don't want their tongue to always be at the bottom as it will block the airway once they sleep. So we want them to be trained to raise their tongue up to the palate behind the upper anterior teeth. As for the tongue crib, this is to help prevent tongue thrusting or tooth licking. So that will prevent those poor habits. And we do have a special trimming protocol because the teeth are smaller around this age group. So we are extending the margins on the posterior area. We have a special trimming protocol for that. So here are our aligner features, the tongue protrusion and tongue crib. So that is a spherical protrusion set on the upper aligner to guide the tongue to its correct position. Now, if you will be sending an STL file for this Smartee Kinder, the STL file should contain the data of the complete hard palate as we are replacing that feature of the tongue protrusion. As for the Smartee tongue crib, it's a pyramidal protrusion that is set on the lower aligner to assist and correct the poor tongue habits. So these are placed on the lower 2 to 2 teeth by default. So the STL files should contain data of the hard palate 3 to 3 or even 4 to 4. We also have options for the trimming protocol for the aligners. So option 1, that is the conventional trimming. It is a scalloped. The edges of the clear aligners are cut along the gingival lines. Now we also have a featured trimming that's special for this kind of series, Kinder and Teen. For stronger retention, you are extending that to the mucosa, maxillary mucosa, to provide stronger retention, and it's more comfortable for the patient. So if you will be requesting for this special trimming protocol, your STL file should contain the data, which includes 2 millimeters up to 3 millimeters over the gingival line on the buccal side of the posterior teeth. Now, the wearing time for Kinder and Teen series, similar to the GE series, that will be 20 to 22 hours wearing time per day. Let me just show you a video on how this clear aligner feature looks like.
The aligner edge extends to cover the gingiva and palatal mucous membrane at posterior area, whereas the anterior area is not covered by the dental sheet.
And here are our myofunctional trainers that come in the package. Joy is an optional device that is not included free in the set, but we do have the Bitey and the Smiley. So what is the action of Joy? We use Joy if we want to coordinate the jaw relationship, the upper and lower arch, improve the arch form. We also need this to guide the tooth eruption, especially for younger patients, to modify the occlusal plane first or occlusal relationship before we jump into clear aligner treatment. So this can also assist in malocclusion treatment to improve on the deep bite first, or deep overjet, or excessive overjet and cross bite. So this is the
Joy
for the
to improve arch form, guide disruption, coordinate jaw, and occlusal relationships for children at mixed dentition period.
So for the Smartee Joy, we have different sizes for that. So this is a clinical guide on how to select the Joy size, and this is based on the dental arch width. So for primary dentition, arch width is about 41 or less than 41 millimeters. So that is the distance between the central fossa of the maxillary 5, right and left. Now we have the early mixed dentition, first molars erupted, anterior teeth being replaced. So it's 41 millimeters up to 45. And we do have the middle mixed dentition size about 45 to 50 millimeters, and late mixed dentition that is more than 50 millimeters. So that is the distance between the central fossa for mixed dentition of the maxillary 6s. We will also help you with choosing the Joy size based on the photos and x-rays you send us. But you can also choose the Joy size for your patient. Now, these are the free myofunctional trainers that come in the package. Bitey plays 3 movements, or we actually do 3 labial muscle training, 3 movements: labial muscle training, tongue muscle training, and masseter muscle training. So what you need to do for labial muscle training is to put on the lip on the tunnel and use that lip together with the teeth and bite that. Use the lip and bite it 20 times per set and do 3 to 5 sets per day. Now, of course, the patients are young, so they might not be able to do that 5 times per day or 3 times per day. You can start them by doing 10 times per set, or maybe once a day first, and then increase that up to 3 to 5 sets per day. So this is how it looks like.
Bitey to enhance strength of soft tissues, including labial muscle, tongue muscle, and masseter muscle.
So that is our Bitey. Now we also have a free myofunctional trainer, our Smiley. So it helps in correcting poor habits such as mouth breathing, lip biting, and finger sucking. So it helps to improve the early deficiency in labial muscle function with short upper lip or difficulties in keeping their lips together at rest. You just pull it out quickly by hand or with external force. So you need to do that 30 times per set and about 3 to 5 sets per day. So you ask the patient to put it between their teeth and lips, close the lips tightly, and pull it out quickly by hand or with external force. Now the patient can also sleep with it. So it acts like a pacifier, but it's not a pacifier. It's placed between the teeth and lips. It just helps them to keep their lips together. So they'll be mindful whenever they're sleeping. If ever it falls out initially, then that's fine, as long as just ask them to put it on again, or maybe in the future, along the way, the patient will be putting it on consciously. So here is the video.
Smiley, smiley. To help correct poor habits such as mouth breathing, lip biting, and finger sucking, etc.
Okay, so we have different recommended treatment plans for our Smartee Kinder according to their dentition, primary, early mixed, or middle mixed dentition. So there are times wherein we just provide first the myofunctional trainers, and then later on we will be recommending a treatment plan with clear aligners, and then with the Joy or clear aligners, and then the retainers after. So we have different treatment plans for this. Our medical team will be able to help you to choose the treatment plan or the best treatment plan option for your patient too. And of course, we will need attachments for kids, especially if we need to perform specific movement. But the optimized attachments for kids are 40% smaller in contact area than those for adults. So there's less foreign body sensation, it's more comfortable, and it has a stronger retention. And the correction process and plan, like what I mentioned, there's multiple plans available depending on the age group. So what you need to do is to submit to us the required diagnostic tools, such as the x-rays of the patient, panoramic and Ceph x-rays. We do need the photos as well. And then you go to fill in the basic information on your Smartee account, choose the Smartee Kinder, or you choose the early dentition, permanent. You have choices there: permanent, early mixed dentition, middle mixed dentition. And then you go to the second page wherein you will choose the package for your patient. And on the third page, you will need to upload the photos and the x-rays of your patient, facial photos and intraoral photos. And on the fourth page, you will need to fill in the prescription. So you have to put in the patient's concerns and the main objectives. And on the last page, you will need to upload the STL files for the upper and lower, as well as the bite registration. And then you submit the case to us. And these are the Smartee Kinder solution. Last webinar, I was able to explain the different Smartee solutions for our adult package, but for our early intervention, Smartee Kinder and Teen, we have a different solution: K1, K3, K4, and K5. K1 is our optimized attachment tailored for children. K3 is the one with tongue protrusion and tongue crib. Now you also have the option to opt not to have these K3 or the tongue protrusion or tongue crib if you feel like your patient doesn't need them. Our K4 is the myofunctional trainer for Joy, which is an optional device. And our K5 is our free myofunctional trainers, the Bitey and the Smiley. So Smartee Kinder has unlimited sets of aligners within 2 years and unlimited refinements too. And we include 2 sets of free retainers at the end of the treatment. Again, this treatment strategy is for prevention and interception of interferences. And solutions included K1, K3, K5, but there are extra charges for different solutions, such as the invisible forwarding mask, traction device, S11 palatal device. If ever you need that for this age group, then that is an optional charge. So this is an example, a pre-treatment Kinder case and the post-treatment. So here's another case study of a 4-year-old boy. Treatment duration was 5 months to correct the anterior crossbite. So our treatment objective is to improve the anterior occlusion, and the treatment plan was to procline the upper anterior teeth, expand the upper arch, and the treatment solution was the clear aligners and the Joy. So this is the pre-treatment and the post-treatment for this 4-year-old boy. Another comparison of the extraoral photos, another case. Post-treatment, this is pre-treatment, and the right side is the post-treatment. These are the extraoral photos. You will see the big difference after using the Kinder. These are the comparison of the intraoral views for this case. So the crossbite was corrected. within 2 years treatment time. And these are the comparison of the OPG and Ceph x-rays, pre-treatment and a post-treatment. So the indication summary for the Smartee Kinder is for anterior crossbite. We can relieve anterior crossbite with this, posterior crossbite. We reduce deep overbite for severe anterior deep bite. The overjet, anterior, upper anterior protrusion, we can also relieve that. We can correct this increased overjet. So there's individual tooth ectopia. We can align those ectopic teeth. We can relieve the posterior Caesar's bite. We can improve on the arch form or reduce the crowding. And we restore the space of the missing tooth. So for space loss, we can restore the space of that missing tooth. So these are the indications for our Smartee Kinder for age group 3 to 10 years old. Now for our Smartee Teen, that's 5 years management. These are for children aged 3 to 16. So we do have the primary dentition, we have the mixed dentition, we do have the early permanent dentition as well. So for this age group up to 16 years old, these are the common dental problems in their occlusal development that we will need to address. Apart from having this anterior crossbite, posterior Caesar's bite, upper anterior teeth protrusion, or anterior excessive overjet, there's also space loss, primary teeth loss, posterior crossbite, severe anterior deep overbite, narrow dental arches and dental crowding, or individual teeth ectopia. But we also can see already their facial prognathism, especially for class 2 malocclusion. That's why for this age group, our treatment strategy is not only prevention and interception of these interferences, the occlusal interference, the myofunctional interference, and their poor habits. We also do guidance and correction with their abnormal dental replacement in mixed dentition or their abnormal development of the maxilla and the mandible. So we want to have a harmonious, more stable and aesthetic facial profile with them. Our Smartee Teen solution comes with clear aligners, myofunctional trainers, but also functional appliance for arch expansion and space maintenance. So similar to the Smartee Kinder, we do have the tongue protrusion K3, we have the tongue crib K3, a liner tripping protocol wherein we can extend the margins for stronger retention, but we also have this mandibular repositioning solution, S8, S9, S10, S11, S16, that we can also see in our Smartee GS package for mandibular advancement. So this is our mandibular advancement for growing patients, Smartee Teen. It also comes with the Smartee hook or the Smartee button. Now the Smartee hook and the Smartee button are integrated into the aligner. That is not attached, so it won't easily slip. It is actually integrated into the aligner system.
With specially designed clear devices such as Smartee's Invisible Advancement Device, Invisible White Plane, Invisible Posterior Occlusal Splint, Invisible Forwarding Facial Mask, and Palate Enhancement Device.
Similar to Kinder, we do have these features that you have an option also to choose or not to have them in the prescription page. And same thing with the aligner trimming protocol. We do have them as well. You can choose between option 1, the regular trimming, option 2, which has the featured trimming that extends up to the gum and palatal mucous membrane. And we have it's for stronger retention. And if you would want to extend the margins of the aligner, the STL file should contain the data, which covers 2 to 3 millimeters over the gingival line. So don't forget that. Again, wearing time for the Smartee Teen, similar to Kinder, is also 22 hours per day, 20 to 22 hours. Now, what are the other features of the Smartee Teen? So we do have the mandibular repositioning devices in them. We have this mandibular advancement, S8. Let us go through them one by one. Let us first start with the S8. Our S8 mandibular advancement is suitable for solving class 2 malocclusion cases. So we have two appliances to use for our S8 mandibular advancement. The first one is the S8 SGTB, that stands for Sagittal Guided Twin Block. And that is to resolve class 2 malocclusion with 3 depths. So what are those 3 depths? deep overbite, large overjet, and excessive curve of speed. But if your class 2 malocclusion case exhibits only one depth or only having this excessive overjet, but the overbite is normal, the bite is normal, and there's flat curve of speed, then we will be using our S8SGHB, which is the sagittal guided herpes type. So that's the difference between the two. Now, if you will be using this mandibular repositioning devices, we do require a special wax bite registration, which later on I will be discussing for submission. Now, another type of our mandibular repositioning device under the teen package is our S9 bite plane. So our S9 bite plane comes in two. We have the anatomical and the non-anatomical bite plane. So what does this do? These are for deep overbite, but straight profile patient or class 1, not the class 2 type. So it creates a vertical space for deep overbite to stabilize the mandibular position, and it also helps to intrude the lower anterior teeth to level the curve of speed. Now, how different is this from the bite traps? If you want to resolve the deep bite for class 1 or straight profile patients, then you can still use the GE package together with the bite traps. But if you want to have a more stable and more harmonious facial profile for your patient, because we will be doing some advancement, then you will choose S9 bite plane to resolve that issue or that kind of case complexity. Now, our S10 occlusal splint is another device under teen, and that is suitable for treating mandibular deviation or for facial retrognathison cases or class 3 malocclusion cases. Now, we also have this palatal device. The palatal device, that is optional. It doesn't come free in the package, but you have the option to choose these palatal devices. So it comes in three. We have the clear arch expander, and we have the clear NANS and the clear TPA. So how does this plastic create that expansion effect? Actually, the material is 0.5 millimeter wider than the actual arch width to create that expansion effect. So it extends from premolar to premolar area, and that is only for dentoalveolar expansion, by the way, not a skeletal expansion. So it is integrated into the aligner, so you don't use a separate expanders or clear arch expander. It comes with the treatment plan. Now, the clear NANS is used to assist with the distalization. It helps to stabilize the posterior teeth. It helps to strengthen the anchorage during distalization. And the clear TPA will maintain the position of the posterior teeth after distalization, thereby assisting in retraction of the anterior teeth. So those are the actions of these palatal devices. Now, the S15 integrated traction device is also under the teen package. We do have two types of this integrated traction device. We have the Smartee hook. So this Smartee hook is adjustable in multiple directions, but it is only a one-directional force of traction. So if you need a class 2 or class 3 elastic, then it is just a one-directional force or one-directional force of traction. It's 1.5 times higher efficiency than the traditional buttons that we place. So this is an option for you to choose for your patient, as well as the Smartee button. So the Smartee button is stronger. It can withstand 3,000 grams maximum force. So that is applicable for traction of all indications and in all directions, because the Smartee button can be angulated according to your direction of force for traction. So you have the option to choose between these two. Now we do have the S16 that is also an optional fee for teen package and kinder. This is called the invisible forwarding traction device. So what is this S16? It's a combination of the face mask, the S15 Smartee button, and the S11 palatal device. Sometimes it also has the occlusal pads. So these combination of the devices are intended to promote the maxillary growth in facial retrognathison cases for those with underdeveloped maxilla or facial retrognathison or class 3 cases. So as you can see, we use this Smartee button so that it can withstand this high amount of force for traction. Of course, it comes with myofunctional trainers too. We have the Joy, which is an optional charge or device. So if you want to prepare your patients for clear aligners, probably there's too much crowding involved, or probably you still need to wait for some vital teeth to erupt as guidance for teeth alignment, then you will have to use Joy first. And then the Bitey and Smiley, these two are free in the package. Again, the Joy is a specialized treatment method during mixed dentition period to improve the arch form, coordinate jaw relationships to guide tooth eruption, and to improve somehow the dental and facial development. Now the Bitey again performs in 3 ways, 3 movements for the labial muscle training, the tongue muscle training, and the masseter muscle training. And the Smiley, it assists in correcting poor habits, including mouth breathing, lip biting, finger sucking, etc. It helps to relieve the pressure in the perioral muscle. So all you need to do is to pull it up by hand quickly, 30 times per set, and about 3 to 5 sets per day. So just make sure that you ask the patient to close their lips tightly while they tug it out. So put it between the teeth and the lips. For the Smartee Teen, we have different recommended treatment plans. We have for primary dentition, early mixed dentition, since we are starting this package from 3 years old up to 16. And what's good with the teen package is because we can pause the treatment 2 times. So again, we can start it for primary dentition, early mixed, middle mixed, late mixed dentition, and permanent dentition. We have different recommended treatment plans for our Smartee Teen. And we also have these functional appliances, if ever that is needed to support our treatment for our patient, then we can also provide these type of appliances. For the Smartee Teen, it's 5 years management. We actually provide 2 free retainers at the end of the treatment. And we have multiple plans available. For primary dentition, it's 3 to 6 years old. Early mixed dentition, that is 6 to 8 years old. 8 to 10 for middle mixed dentition. 10 to 12 for late mixed dentition. And up to 16 years old, from 13 up to 16 for permanent dentition. So we have multiple plans available for them. So in submitting a case similar to Kinder, just go to your account and then you fill in the basic information of your patient. Step 2 is to choose the product series. Now, if you are unfamiliar with the description of this product, then you can click on the detail button so you can see what is included in that package. So for Smartee Teen, it's 5 years warranty with unlimited stages and unlimited refinements. We will also be needing photos and x-rays as well. But if you will be doing a mandibular advancement using the S8, S9, or S10 devices, then you will have to submit a wax bite registration, an STL file, and also photos with the mandibular reposition. But we also can do digital advancement if ever that you cannot perform that with your patient. So you also fill in the prescription page that is required. But if you are not sure about the device that you want to use your patient, we have the device options here and we have the description to each devices. But if you are not sure, then you can leave it for the Smartee medical team to decide, depending on your case. And then the step 5 STL file, if you will notice that there will be 2 areas wherein you will be placing the STL file. We have the original bite position and we have the mandibular position, repositioned STL file. So if you will be doing the mandibular advancement for growing patients, if you have class 2 malocclusion with 3 depths, for example, then we will be using our SGTB or sagittal guided twin block. Now it will be a 2-phase technique, meaning to say we do first the phase 1, which is the orthopedic phase, because we want to stabilize the jaw position first. And we go to the second phase, which is the orthodontic phase after we have stabilized the position of the jaw. Now, for phase 1 staging of SGTB teen cases, normally we are providing up to 40 sets. Now, the 41st and the 42nd set, that is a passive aligner while waiting for the next phase to arrive. What do you expect with the phase 1 staging for SGTB cases for teens? Stage 1 to 6, we are providing 2 sets of aligners. So why do we provide 2 sets? Because we are expecting that they will have difficulty eating with it. Now, the difference with using the mandibular advancement devices with the regular aligners is that for mandibular repositioning or advancement devices, they have to wear it 24/7. They only remove it when they need to brush their teeth, but then they have to wear it even while eating. That's why for stage 1 to 6, that is for mandibular adaptation. No tooth movement is designed, but the block is there as we want them to get accustomed to it. And we are providing 2 sets per stage. So for stage 1 to 6, please expect 2 sets per stage. Now, stage 7 to 37, that is the mandibular repositioning wherein tooth movement is designed, but the block is still there. And around the stage 38 to 40, you will notice that there's mandibular retention already. That is considering that the patient is compliant in wearing the aligners 24/7, okay? You will see no tooth movement because we are retaining the position of the mandible around 38 to 40, and then we take the oral scanning around the 40th stage for the second phase of the design. Now, if you will see your animation on the first phase, you will notice a jump from perhaps the 40th up to the 41st or 42nd, because we want to simulate the final position of the second phase. So it's a good thing for you to show your patient that that will be the final position of the second phase. Now, what do you expect for the phase 1 staging of the SGHB teen cases? Remember, our SGHB comes only with that wing type or the herpes type, doesn't come with a block. So we don't have this positioning, mandibular repositioning, mandibular adaptation stage. We only have the mandibular repositioning stage 1 to 37. Tooth movement can be designed already because we are not waiting for the mandibular adaptation to happen. And around the 38 to 40, there's mandibular retention, wherein no tooth movement is designed, but the herpes may still be there. So we take the oral scanning for that on the 40th stage. And then you will see the simulation of the final position from 41 up to 42. Simulation of the final position. Going back to this phasing, we recommend for the first phase for you to see the patient after 2 months, because we want you to observe how the patient is accustomed to wearing the aligners even when eating. And on the 4th stage, we want you to recall your patient again for a visit. We want you to see, the difference with the facial harmony. It should be more relaxed position for the advancement, but the mandible can still protrude back to its original position. That is normal. But around the 7th month, you should see your patient again because we recommend for you to take the OPG or CBCT to see the new cortical outline on the condyle. So you should be able to see the midline corrected, and you will see the remodeling of the condyle or the new cortical outline around the 7th month. Then around the 8th or 9th to 10th month, by then you're able to finish the staging and you can observe the stability of the jaw. So the mandible should be stable and can no longer retrude back. You need to observe the curve of speed. If it has leveled from 5 millimeters to around 2 to 3 millimeters, it's a sign for you to go to the second phase already. And if you see that, so those are the things that you need to see before you jump into the second phase. So here is the summary for our Smartee Teen indications. We can relieve anterior crossbite and the posterior crossbite. We can reduce the excessive or deep overbite and excessive overjet. But with a teen, we can also correct or improve the abnormal arch width, their length and morphology. We can do already molar distalization. We can improve arch length and the facial prognatism. We can improve the facial profile without having to go through extraction or even surgery in treating class 2 malocclusion. So we can shift from class 1 up to class 1 molar, from class 2, class 2 up to class 1 to a class 1 molar relationship. And we can use this for space management, if especially during mixed dentition. We can align the dentition and improve the dental space. So if you will notice, our Smartee Teen solution is greater than Smartee Kinder. So apart from having the K1 up to K5, we have the K1 optimized attachment for children. We have the tongue protrusion and tongue crib, K3. We do have the optional device K4 for My Functional Trainer, Joy. We do have the K5 My Functional Trainer that's free in the package, Bitey and Smiley. We also have this solution for adults. For teen, we have the S8 Mandibular Advancement Appliance, S8 SGTB Sagittal Guided Twin Block, S8 SGHB Sagittal Guided Herps. Again, SGTB is for 3 depths. Class 2 malocclusion, deep overbite, excessive overjet, and deep curve of B. But for HB, that's only for 1 depth. Malocclusion for class 2 is for excessive overjet only. Now for the S9 invisible bite plane, we both have the anatomical and non-anatomical type. This is to treat deep overbite for straight profile patient. S10 is the one for mandibular deviation. We want to correct them. We want to disclude to be able to correct them. And also we can use this for facial retrognatism. And we have different wax bite registration to follow. We have protocols to follow for this. S11 palatal device is actually an optional device for teen, but we can perform 3 ways. 3 kinds of palatal devices, what I mean. So we have the clear arch expander that can help to be more efficient with our arch expansion. We have the clear NANS to help with the distalization. It assists in strengthening anchorage in distalization process. We have the clear TPA to retain the position of the posterior teeth, thereby retracting the anterior teeth. So these 3 palatal devices are part of the treatment plan. So our medical team will be the one to design the animation for you. We have S15 integrated traction device. We have the hook, which is a one-directional force, a Smartee button that can withstand 3,000 grams maximum force for all kinds of traction direction. It can be angulated according to the direction of traction. And we do have S16, invisible forwarding traction device or elastic device. It comes with a face mask too. And this is also optional in the teen solution. So summary for Smartee Teen is 5 years management for ages 3 up to 16 years old. And you can pause the treatment 2 times. So what does it mean by pausing the treatment before the age of 16? Now, if ever you started your patient perhaps 7 years old and you finish the treatment in less than 2 years, or perhaps about a year, and you still have 4 years remaining. For example, you have finished your treatment with a 7-year-old patient. You finish them by 8, but patient is at 8 years old, right? So you still have 4 years remaining. You can pause the treatment up to the age of 16, so you can continue on while waiting for the eruption of those permanent teeth. So our treatment strategy, again, for teen is not only to prevent and intercept these interferences, the occlusal interference, the myofunctional interferences, and the poor habits, but we can also guide and correct them as well. Improve the facial profile and correct the teeth simultaneously with orthopedic and orthodontic treatment using the 2-phase technique. This is an example of a case study of a 14-year-old boy, facial prognatism and crowding, but the treatment duration is 33 months. Again, the treatment duration varies. It depends on patient compliance, because we all know that for clear aligners, patient compliance is a must. Now, if the patient is not that compliant, we may result in numerous or multiple refinements. And that's why it's very important for you to strengthen your clinical monitoring. So with this case, SGTB was used to do mandibular advancement and to perform arch expansion. So from class 2, it was, class 1. This is class 2, but it was resolved to class 1. And this is an actual case in Manila. So this is before and after mandibular repositioning using SGTB. This is only 9 months after the treatment. So if you will see, there's really an improved facial profile, significant improvement. So this is the first phase, orthopedic phase. Now the patient can smile better. If you will see, the chin that is, or the mandible that's protruded has been corrected as well. And this is now stabilized. It's ready to go to the second phase. So this is without extraction for class 2 malocclusion. Going back to the wax bite registration, we have a manual for you to follow for getting the correct wax bite. We've talked about the S8 SGTB sagittal guided twin block mandibular advancement. We have classified that into 3 classification. So we have the dentoalveolar, meaning to say that the teeth are protruded, but there is no prominent bone. For those type, we call that dentoalveolar in origin. Now, the second classification is what we call subtype 1 or mandibular retrusion, subtype 1. So that is, or skeletal 1. That is with prominent bone, but the teeth may not be protruding. Again, the S8 SGTB is for class 2 malocclusion that has 3 depths. Combined subtype 2 or combined mandibular retrusion skeletal 2, that is for prominent bone with prominent bone, but the teeth are retruded. So how do you go about with your wax bite registration? Please be mindful of these 3 directions. We have the sagittal, vertical, and horizontal that we need to follow. Again, for S8 SGTB, for sagittal, and you have classified your patient for dentoalveolar, your direction should be 2 millimeters overjet. Anterior overjet is 2 millimeters. So when you move the jaw forward, be mindful of the sagittal direction. For the combined subtype 1 or the mandibular retrusion skeletal 1 with prominent bone, you line it up edge to edge. So anterior teeth should line edge to edge in incisal position. As for the mandibular retrusion skeletal 2 or the one with prominent bone but protrusive teeth, you have to compensate for that retrusion. So it has to be a reverse overjet of 1 millimeter, a crossbite of 1 millimeter. Now, vertical height should be considered. The height should not be less than 5 millimeters. It should be at least 5 millimeters in height. Okay. For the horizontal, for all types of our mandibular repositioning devices, it always has to be in line with the chin point. So the dental midline, the facial midline, and the chin point should all be coordinated and centered. Now, HB is quite straightforward, the one with herps, because we know that it doesn't have that deep curve of space, so we don't compensate that with a block. We only use the herps type or the locking device. We only line it edge to edge for the sagittal direction. So these are for mandibular retrusion caused by condylar resorption. The vertical height should not be considered because once you line it edge to edge, you don't need to mind the vertical height. But the horizontal should always be in center with a chin point. For the S10 devices, so we have 2 type of cases that we can use this for. The first one is for the mandibular deviation. So we need to do a lateral shift or correct the lateral shift. That's how you do it for sagittal direction. But for the height, it's not as large as what we do for SGTB. At least 4 millimeters is enough. For the S10, if you want to correct the facial retrognatism or class 3 cases, similar to the S10 for lateral shift or mandibular deviation, you also do an edge to edge. Sorry, let me correct for the lateral shift. No need to do edge to edge, but correct the lateral shift for mandibular deviation. But the edge to edge is for the facial retrognatism or class 3 cases. Now, what if your class 3 case or facial retrognatism cannot perform edge to edge? I think that is the limitation for you to use our S10 appliance. Okay. Now, using the S9, it's just relieving the anterior, correcting the normal anterior overjet. And then no need to consider for the vertical height. This is the quick classification for the facial prognathism, the one that I've mentioned earlier. So we classify the fundamental skeletal is for the SGHB, exhibiting only one depth, which is excessive overjet with shallow overbite and shallow curve of speed. So it's straightforward, just line it edge to edge. Now, there's 3 types below, mandibular retrusion. So they have common denominator here. All exhibits mandibular retrusion. Dentoalveolar, meaning to say the teeth are protruded, but there's no prominent bone involved. But the skeletal 1, skeletal 2, those are prominent bone, may not be protruding teeth or with protruding teeth. That's why you need to perform that kind of wax bite registration, the one that I've mentioned earlier. So how do you take your wax recording? Once you take the STL file for the original bite position, you have to take another scan. You scan first the upper and the lower teeth. After doing the scanning, you have to practice your patient and how to move the jaw forward. So remember the 3 directions that we need to consider. Sagittal. Again, go back to the classification. If it's dentoalveolar in origin with no prominent bone, you have to do a normal overjet, which is 2 millimeters overjet. That should remain. Now, if our classification is a prominent bone with 3 depths, then you have to do an edge to edge. So that's how you do it. The 3rd classification with retroclined teeth have to do a reverse crossbite, reverse bite, or because it's crossbite, so you have to do that. A reverse crossbite, 1 millimeter crossbite. Okay, now what if, because you need to have a vertical height of 5 millimeters, right? So you have to open the anterior if it's not enough. For example, you need to do an edge-to-edge bite, but the vertical height is not enough. So you have to raise the anterior bite about 1 to 2 millimeters to have that 5 millimeters vertical height, because we need to place a block. Lastly, the horizontal direction, transverse, always coordinate with the chin point, dental midline, facial midline, and the chin point. Once you have practiced your patient on how to do it, then you get the pink wax. What I do is I cut my pink wax into 2 and then soften it in hot water, roll it, fold it once. That wax should cover only 3 to 3 areas, canine to canine or premolar to premolar areas. Place that behind the upper anterior teeth. Slowly move the jaw forward and guide them according to those 3 directions. Make sure that the frontal areas are clear because we will have to do a scan for the front and the sides. We also need photos of the reposition bite. So you need to take photo left, right, and also the center. So it has to be clear of wax. Otherwise, you can't scan it. And then take the recording. So this is what it will look like. So we will need 2 scans, original bite position and the repositioned bite position for STL. Now, for patients who are really having difficulty moving the jaw, or perhaps the doctors are having difficulty doing that, then we have the digital advancement. We can perform a digital advancement for you. So you don't need to perform this wax bite registration. So that is a summarized step for wax recording. So if you go to your STL file page, you will see here a question. Do you require digital simulation? If you say no, then we will be needing 2 STL files, original bite registration and the mandibular repositioning STL file. But if you will click yes, then you can only submit the original bite registration. To summarize our Kinder and Teen, we have this product series and solutions and the difference from Kinder and Teen. So there are more solutions if you will choose the Teen package compared to Kinder. Because our treatment strategy, again, with Kinder is only prevention and interception of the interferences, but for Teen, it's with guidance and correction. So these are the different solutions for Kinder and Teen. Now for arch expansion, you may be wondering how much of expansion can we do for Kinder series. So for Kinder series, arch expansion amount should be controlled to approximately 3 millimeters per side. So it's a total of 6 per arch. So if additional expansion is required, you have to use an active appliance. We advise that to provide further assistance. Now for teen series, we recommend that arch expansion is up to 2 millimeters per side. If greater arch expansion is needed, then we recommend a fixed arch expansion device to achieve the desired results effectively. We also do have recommendations for usage for our clear aligners, our myofunctional trainers, and our functional appliances. Again, for clear aligners, 22 hours each day. If they cannot perform 22, maybe at least 20 hours per day. And they need to remove the aligner while eating, except for the ones with mandibular advancement. They have to wear it 24/7. And the wearing time is about 7 to 10 days each. But the one for mandibular repositioning, we recommend 10 days for each stage. Now the bitey, the practice times 3 to 5 times each day. And for each set, it should be around 20 times and 3 to 5 sets per day. Smartee, they can wear it 2 to 3 hours per day. Nighttime, they can wear it throughout nighttime. Joy is optional, 2 to 4 hours each day, and they can also wear it throughout the night. So here are some FAQs in making sure that the mandibular repositioning performs well, or how different is our mandibular repositioning from the others. So we offer 2 sets per stage for the first 6 stages to make sure that the adaptation, is sufficient for them. And we are providing, we do not provide additional sets for the bitey and Joy and Smartee. So here are just some of the important reminders for using myofunctional trainers. So these are silicone products, and we advise them not to eat or talk with it because those are silicone. Material is just silicone. And it will be the doctor's discretion or decision whether you need this myofunctional therapy with your patient. Since it comes in the package, you have the option not to use them, or maybe use them for your other patients that need it. That's it for tonight, and thank you for listening. Good evening, everyone.